I was proposed to choose this topic, non-surgical methods of atherosclerotic treatment of brachiocephal arteries. I am as a therapist and cardiologist. I think that number one is a healthy lifestyle, and then pharmacotherapy, and then, who is lucky, surgical methods and correction. I'd like to draw your attention to the fact that formally we comply with the Russian recommendations based on the recent European ones of 2011 and our review 2012, and partly on the American ones. Formally, formally everything is very easy. We should step from the fact that each patient should be graded according to the class and according to the evidence based of this precise method of treatment. It's very important to emphasize that. Sometimes we are confused. Well, we should apply pharmacotherapy, or maybe it shouldn't be applied. Class Y, useful effectively, it's indicated. Without thinking, class 2, there are there should be conceded because there are some evidence. Class 2B may be conceded according to the opinion of a doctor what kind of medication to use or not to use medication at all. Levels, especially A and C. A, when we have the data of several randomized clinical trials, and C, when the experts agreed, when it's impossible or not have time to do large randomized clinical trial. It's important to know because when we have 50-page guidelines in hands, even according to the color, we should have our landmarks. And this slide I'd like to show you. In our functional recommendations, and I was involved in the development of these recommendations, 8.10 patient with the peripheral arterial diseases, even a carotid atherosclerosis patient, class 1 in C. Expert conclusion, statin therapy to prevent progression of the aneurysm of atherosclerotic abdominal part of aorta. We should know this for sure. Medication of choice for patients with atherosclerotic or peripheral arteries, statins, plus combination nicotic acids, statins plus Zitrol. It's proved that it's not less effective as a monotherapy of statins. Monotherapy to prevent progression of atherosclerotic carotid arteries. The level A, several large randomized clinical trials. As to the stroke patients, it's clear now that there is a relation with lipidemia and the development of ischemic stroke. So statins with patients are ischemic strokes, and hemorrhagic stroke is contraindication. Class A1, level A. Up to the date, there are no doubts. Our collaboration with surgeons is very tight and very fruitful because we speak the same language. People with high risk, they are recommended statin to achieve a target level. The target level is 1.8 for high-risk patients of lipoprotein of low density. According to American recommendations, we should decrease at least 50% of the basal level. If we do this, we can reach our target level. And statin is recommended for patients with ischemic stroke because of the atherosclerotic impairment of cerebral arteries. And we have the terminology atherosclerotic cardiac vessel disease. METEOR study on statins at the level of low progression and asteroid high stenosis, and it's proved that statins are effective. Arion study, clinical trial, they proved that the core of the plaque is decreasing. It's an image from the trial on carotid arteries of rostatin in 2 years without statins. Monotonous increasing of the intermedia complex, and against the background of high dosage of rostatin, stabilization and even lowering.
Presentation. We believe that the pharmaceutical therapy is efficacious only at the early stages of vascular diseases and as a adjuvant therapy to surgical intervention. As for the advanced stages of this disease, uh, we believe that there are no efficacious regimens of pharmaceutical therapy. Nonetheless, oftentimes we compare safety and efficacy of revascularization with standing or with statin therapy. Yeah, and it may be an alternative for the patients who already underwent coronary vascularization. And that's my question. And should we anticipate that pharmaceutical therapy in the context of cholesterol lowering medications like statin, should we anticipate it as a treatment modality? Can we hear me? Yeah, we can hear you. I believe no. It's not an alternative, and it won't be. But as for complementary to endovascular intervention, certainly. As for alternative, there were some indications, but they are not supported by evidences nowadays. The atherosclerosis is a systematic disease. This year, your patient developed a stroke. Next year, the same patient will develop a myocardial infarction.